Today, we're going to talk about cerebral metastases, what they are, how they affect patients and families, and how we care for them, both medically and as nurses at the bedside and beyond. Cerebral metastases, or brain metastases, happen when cancer spreads from somewhere else in the body into the central nervous system. That includes the brain, the cerebrospinal fluid, and the meninges. They're actually more common than primary brain tumors, and unfortunately, the 2-year survival rate is still under 10%. But the reason this matters now more than ever is that people with cancer are living longer because of better treatments. That means we're seeing more neurologic complications, and as nurses, we have to know how to recognize them, manage them, and support both patients and their families through it. Patients with cerebral metastases can present with a wide range of symptoms. These might include headaches, difficulty walking, vision changes, personality shifts, memory problems, weakness or paralysis, trouble speaking, or seizures. When the cancer spreads into the CSF and meninges, a condition called leptomeningeal metastases, you may see isolated cranial nerve symptoms like facial droop, hearing loss, or vision problems. These changes can be extremely distressing, not just for the patient, but also for the people around them. Recognizing these signs early and knowing how to respond compassionately is part of our role. Now let's talk about how these patients are treated. The main goal is palliation, relieving symptoms and maintaining the best possible quality of life, even when a cure isn't possible. Treatment often includes whole brain radiation therapy, especially when there are multiple metastases. If there are only a few lesions, usually fewer than 3, stereotactic radiosurgery might be used. In some cases, surgery is done for a single symptomatic lesion. Chemotherapy is used selectively depending on whether the medication can cross the blood-brain barrier. If the cancer has spread into the CSF, intrathecal chemotherapy may be considered. This involves injecting medication directly into the spinal fluid. Pain control also becomes a major priority. In more severe cases, pain medication may be delivered directly into the epidural or subarachnoid space, right near the spinal cord segment affected by the tumor. From a nursing perspective, our first responsibility is assessment. That includes evaluating neurologic baseline, how the patient is walking, talking, eating, seeing, and their level of independence. Can they feed, bathe, or dress themselves? How is their cognition? Are they oriented, confused, withdrawn? We also assess quality of life. Are they sleeping, eating, managing pain, or having seizures? Respiratory function and bowel or bladder patterns are part of that bigger picture too. Malnutrition is common, so we evaluate intake, recent weight loss, BMI, and related labs. And beyond the patient, we also assess the family. Their emotional, financial, and caregiving capacity matters when we're thinking about the full plan of care. Based on what we find, common nursing diagnoses include impaired self-care, altered nutrition, anxiety, and interrupted family processes. Complications we watch for most often are seizures and headaches. Once we've done that assessment, we focus on our goals. We aim to support self-care, improve nutrition, decrease anxiety, strengthen family coping, and prevent complications wherever possible. Let's break down the specific interventions. First, we support self-care and coping. That means encouraging independence as long as it's safe, involving the family in care without taking away the patient's autonomy, and bringing in the interdisciplinary team, physical therapy, occupational therapy, chaplains, social workers, and hospice. We help the patient stay grounded by focusing on short-term goals, one day at a time. And when the time is right, we refer to home care or hospice. Next, we focus on nutrition. These patients might have nausea, fatigue, pain, or no appetite. So we time meals when they feel best, keep the environment clean and free of strong smells, and serve foods they enjoy. We educate families on safe positioning for meals and use oral hygiene to stimulate appetite. We track weight and intake and loop in the dietitian early. If they need tube feeding or parenteral nutrition, we monitor closely, but we also stay flexible. We never want meals to become a source of stress. And if steroids are part of the treatment plan, we watch for increased appetite, weight gain, and high blood sugar. Managing anxiety is another key part of our role. Patients may feel fear, anger, sadness, or even paranoia and mood swings. Our job is to listen, acknowledge what they're going through, and provide presence and reassurance. We may use touch, encourage visits from family and friends, and involve mental health support when needed. Some patients find comfort in journaling, prayer, relaxation exercises, or even just setting one small goal for the day. Families need support too. We help them understand what's happening, reassure them about the care their loved one is getting, and offer practical help. We teach them about symptoms and what to expect, offer connections to hospice or home health, and help them adjust to a new normal. Groups like the American Brain Tumor Association can offer excellent resources, and it's part of our role to point them in the right direction. Finally, we plan for transitions. That might mean home care, hospice, or palliative services. We make sure patients and families are prepared with instructions about symptom management, IV care, pain control, and infection prevention. We emphasize the importance of calling for help before a crisis happens, and we reinforce end-of-life goals with dignity and respect. We evaluate our success not just by lab values or vital signs, but by outcomes like this. The patient is still participating in their care as much as possible. They're maintaining some nutritional intake or comfortably accepting alternatives. Their anxiety is decreasing. The family is engaged in coping. Seizures and pain are well managed, and everyone involved knows how to get help when they need it. Caring for someone with cerebral metastases isn't just about managing symptoms. It's about preserving dignity, fostering connection, and offering steady, compassionate support in a difficult season. Our presence matters, our patience matters, and our voice can make all the difference.